Morning, everybody. Thank you for being here. And we really appreciate, I know everybody is kind of zoomed out and Zoom full every day. So we appreciate you making the effort to be here. But I think it's important that we keep we really have our eye on the long term and where we're going and continuing our progress here. Um, as you all know, today the possibility started for people over the age of 75 to get their vaccines. As I understand it, the phones are blowing up. The governor was telling us last night that he thinks we are at a place where the end is in sight. So hopefully that is true. I want to spend a little bit of time this morning doing what those of you who've been with us for a while know that we do. We try every year at the end of the year to look back over our overdoses during the year and see if there are pieces of information we can pick up. Because of the notice we get about those deaths, see if we can see similarities, see if we can see things that will be helpful. You will remember, and one of the things that has really made a big difference was 3 years ago, we were seeing that very often in a fatal overdose, family members were able to give us a pretty exact time when they knew their loved one was last alive because they were reporting that they heard that deep, wet kind of snoring, or what they believed to be snoring at a certain particular time, when they went to bed, when they got up, whatever. Of course, we know that's the distress breathing and signaling an overdose, and then we wanted people to be learning that and using that time to call the police, use Narcan if they had it, all of that. We took that piece of information. We got Channel 5, their 5 on opioids to help us. In the days when we used to be able to go places, made a real tour of the county to the Rotaries and all kinds of groups that would have us to talk to people either who were struggling or who loved somebody who was struggling, to say, when you hear that, do not continue on to bed. Do not think as a parent, good, they're home and go to bed or go to work, but take some action. The next year, what we saw was, although the number of overdoses did not decline, we saw a 19% decrease in overdoses that went from fatal to non-fatal when that snoring had been identified. So lots of times you can't measure what you prevent, but that was a very specific case where we could see that people took that piece of information, were calling the police, the person had still overdosed, but they were in a position where they were able to get help. So that's the kind of thing we're always looking at to try to figure out. So we're beginning that process, and we have a little bit of information. Let's start just by looking at the numbers if we can. You will remember I began this task force right at the end of 2012, the beginning of 2013. One of the most frustrating parts of this drug, particularly around opioids, was that from 2013 through 2016, despite the amount of time, talent, and real treasure, money, that we were putting into this, our numbers continued to go up. So we went up through those 3 years. It was finally in 2017, for the first time, we saw the numbers come down. And the slide's a little bit different. You got to go to the right-hand side. In 2016, we hit what was for us our highest point, which was 251 deaths. By 2017, we were able to bring that number down to 222, and 153 of those were determined to be opioids of some sort, is what we learned from the toxicology reports. So that taught us, and what we have tried to share with other places who are tackling these issues, is the runway is long. It took 4 solid years of building partnerships, really investing, really working before we saw a change. Because in those other years, despite how hard we were working, the number kept going up. We have been able, since that time, since we turned that corner, to keep that number going down. And as you see, it's continued to go down each year. That is contrary to what has been happening across the state. And what we've also been able to do is bring down the percentage of those that are opioid related. So it is our expectation we're going to keep doing that. And you know, when you think about from 2019 to 2020, it declined by 3. That is, first of all, it continues the right direction, but it's also 3 people in their circle who are not impacted by an overdose death. So given the size of Middlesex County and given the fact that the numbers are going in completely the wrong direction throughout the rest of the state, this really is a testament to the work you can do when you work in collaboration the way we have done here. Again, this is just a reminder, in 2020, this is Middlesex County. Each one of the marks in a city or town shows you there was an overdose, and then you can match up in this little legend on the left side what the drug was. So you see, every red mark is a heroin death. We are seeing lots of other things. We're also seeing a fair number of prescription drugs and a return, which really is different, had been different than probably the last 15 years, a return of cocaine, often as a vehicle for fentanyl. We had not seen cocaine cases here for a very, very long time. And then looking at this year, this is what we've seen so far as of the 12th. And it gives you another sense, just in terms of that, you know, no part of our county, and we have very diverse parts of the county, no part of the county is immune from having these deaths. And reminding you too, just if we go back to the 20, Megan, Nora, please, 2020. If you take a look at this, you see we continue to have issues up in Lowell and Tewksbury, where we have from the beginning, although that has declined dramatically. We've got issues in the lower part of the county, in the Hudson, Marlborough, Framingham, and we have issues in the far right, in what are our more densely populated city areas. I always say the other thing you would see here is if you remember those old map books that kind of had overlays, the plastic overlays, if you took this map and overlay the state highways, you will see that lots of overdoses occur close to highways. So there's often an arrangement to buy. So things like Waltham, you know, that's a place where 128 is going through there. If you go up by Pepperell, the road, a lot of the roads going up into Vermont converge there. So we see them sometimes in places you wouldn't necessarily expect, and it is often maybe people traveling into that community, making a purchase and using right away. All right, so if we go back to the ability to understand what we have continued to see, and this is, can we just back up one? All right, this is the city and town breakdown. This is a very dramatic change. In 2012, 13, we were seeing overdoses happening literally everywhere. In alleys, in public restrooms, in the public library, any place, on the street, wherever it was. We have begun to see in the last couple of years, and it has been true here, that, and it speaks to, I think, the length of addiction and the isolation of somebody who's so deep in their addiction. The vast majority of our cases now are happening in people's homes. Most often either in their own bedroom or perhaps a basement area that they're using for sleeping. And 79% of that, can we get to that slide? There we go. Whoop, the 79%. Oh, no, that's back up one more maybe.
No, so the problem that we had this year was with the data.
Okay.
On where, so I only had the data on
okay.
The house on a small number of them.
Okay.
So I'm hoping to be able to back into that by reading some more of the police reports.
Okay, but I can tell you, having read those read through those, we are still seeing that. I mean, we
Mhm.
occasionally, I think it speaks to a lot of things. It speaks to the training we have given people. So I think, you know, at Dunkin' Donuts and Burger King, they're getting trained better about keeping an eye on those restrooms. I think people are more conscious when they see somebody in a car that may be nodding off. But it really does speak to that long-term abuse and isolation that they're dying at home. And also to that widely held belief among people who are using that you are safer to use at home, especially if there is a non-using family member. All right, so we've got this town sheet. You can look, if you look sideways and see the towns, you see, we continue to see what I mentioned on the map. Framingham, Lowell, Tewksbury, and Malden, not far behind, continue to be spots where our numbers have unfortunately stayed very much the same.
Mm.
And then looking at the month of when people die, and you'll see for some reason in June, and this was true, we couldn't figure this out. In June, our numbers plummeted. We don't know what that was, whether it was better weather and people were finally able to get out of the house or something. But we always see that return at the end of the year. And we will at some point be able to have been able to track through looking at days of the week and months of the year, times of the day. We continue to see an increase around the time when many people receive some sort of support payment. So around the time when people may get some kind of unemployment check or some benefit check. They're very closely aligned. And then as you would expect, we continue to see weekend use being higher than often during the rest of the week. And again, these are the things we've so far seen as very clear trends. You know, we don't see here, as you can see, the snoring, which was there for a while, because that really, I think, has become a part of our work, and it's a part of the education piece we've been doing. It is that much longer, families relating, really decades-long history of addiction, as well, often as having had an extended period of sobriety. The indecent suicidality, we are seeing a lot of these, in addition to the ones that we are able to clearly identify as a suicide, you know, for all kinds of religious, cultural reasons. The medical examiner will not call something a suicide unless there's some very clear indication, usually a note, something to that effect. But there are a fair number of these that we are seeing where either we hear from family, you know, within the 12 hours before the person was found, they gave away their dog and the keys to their truck. It is not my belief that that happened and then they had an accidental overdose. You know, we're finding certain things. They may have left certain paperwork around. Again, I don't think that's a coincidence. The polysubstance use has risen dramatically, and that has played a role in a number of these. And again, as I mentioned, with respect to the being at home, if there ever was a social use piece to their addiction, that has really changed. And there is the social isolation that comes with long-term addiction. So that is the beginning of our look at where we are from last year. We'll continue to refine that and continue to look at what we're able to bring out publicly in terms of helping people to deal better. People have any questions for me about the trends or what we're seeing, those numbers, any of that? All right.
Mute yourself if you need to.
Oh, sorry. Did somebody have a question?
I just,
My name is Janice Saul, and I'm a doctor, I'm a surgeon. And one of the things that I have seen, I am presently semi-retired. I guess I'm not supposed to be speaking. It says,
no, you're good.
No,
You're
go
good.
ahead.
no, there's a little thing that came up on the computer, said the host has spoiled this for the video, but I don't care if I'm on the video.
That's okay. We're done. We're done with the video.
May I just tell you that one of the things that I found difficult, I had to have a reconstructive wrist surgery, but as you offer yourself to whether give shots or drive people. I think one of the things that happens to some young people in beautiful homes is that they don't have a ride to go to the methadone clinic.
Right.
They don't have their license anymore.
Mhm.
They may not have their parents anymore. They may not have their college scholarship anymore. And so I guess that's a question where I ask myself, how do I step up and how do I participate? And clearly, I've written to MassGov and Red Cross, and it's like, if you want me to give shots, I can give shots. You want me to distribute vaccination? Not sure which one's quite perfect, but anything's better almost than nothing. So that's really where I mean, I feel like I'm a high end player, not getting off the bench.
And you really raised two important issues for us, one of which has been, and to the extent that the virus and shutdown has brought us anything, I think at the beginning of this process, you know, the whole thing was how could people get their methadone? What would we do? All of that piece. And there was a real concern, as there has been for years, about if we distributed methadone, if we mailed somebody their methadone or gave them a week's worth of methadone or whatever, would that be misused? Well, what we know now is about a month into the virus shutdown, they did begin doing that, making the distribution easier so you didn't have to go every day, which in Middlesex County, you know, 877 square miles, a lot of it not with public transportation, is an issue. There have been exactly 6 cases in Massachusetts where the medication was diverted or misused. So yes, 6 people did do something they shouldn't have done with their methadone, or somebody did something with their methadone, but the vast majority of people were able to get what they needed and not have to make that trek or be less than socially distanced from people. So that is a piece that I really want to hang on to. The same is true with a lot of programs. You know, it's very hard for lots of people we deal with to say, I know you live in Pepperell, but could you please take a cab somewhere? Yeah, take a cab or something. They can't do that. But the fact that there are online services and at every hour of the day has made a huge difference. And then finally, some of the groups we've been partnering with, that ride piece is huge. And Nora, remind me, I forget the name of the group that comes all the time, the drums, that program, which.
Yeah, so the Mighty Drum folks do a rides program, and then at the end we were going to, which we may as well jump to that, you were going to do an update that we got from the substance use helpline. They have a Rides of Hope program, and that is now up and running. Let me just grab that information.
Okay.
It had been, we had the first 5 months of it. It was really, really successful. But it's Wheels of Hope, and it's a program of the Substance Use Helpline, and they have relaunched their program. So it's in, and I'll put all this information in the chat, but it serves a variety of communities in Middlesex. And if you have a spotted detox, residential treatment, sober housing, if you need access to medication for addiction treatment, they will provide free, safe, and confidential transportation. So I'll put that in the chat, and then I'll put in the chat the information about the Mighty Drum folks as well, so that that information is there.
Great, thank you. All right, so on to our speaking program. I'm really happy today to introduce 2 members of the leadership of the Mass Pain Initiative, Mass PI. And Mass PI is a statewide nonprofit volunteer organization, which is dedicated to ending the suffering that many, many people have from persistent or acute pain and improving the quality of life for the folks afflicted by that pain. Mass PI, much like our group, is really an interesting organization in that it includes healthcare professionals, pain sufferers, as well as community members who are interested in this issue. They share acute pain management information, educate professionals about state of art and the science of pain relief, and work to lobby government representatives to change law and regulations around the management of pain and pain assessment. We were introduced by this group to this group by Dr. Baveld, an active member of the Newton Task Force and a physician at the Newton Wellesley Pain Practice, who works with people who are grappling with addiction but still struggling with pain for which they need some help. I thank her for that introduction. I welcome Mary Jane Estrada and Anne Marie Hertunian. And Mary Jane's been a nurse practitioner on the pain service at Newton Wellesley since 2016. She is chair of Pain Champions and co-chair of the Pain Subcommittee. She serves on several of Newton Wellesley's committees and opioid task forces, and as well as those in the Mass General Brigham system. She was the lead nurse practitioner for a number of years at Boston Pain Care, which is an interdisciplinary pain clinic in Waltham. And she also has experience in primary care and thoracic surgery. Anne Marie is a nurse practitioner as well. She recently retired after 30 years, starting as a child, I assume, working in pain management, and is the co-chair of the Pain Initiative in Massachusetts, where she's been involved in on the steering council since it began now about 22 years ago. So thank you both. I'm looking forward to this presentation.
You're welcome. I'd like to introduce myself. I'm Anne Marie Haratunian, and my colleague is Mary Jane Estrada Leiter. And we're both NPs working in pain management. I'm co-chair of the Pain Initiative, and Mary Jane is co-chair of the Education Council. We have councils in the Pain Initiative that have specific functions, and we have one policy council, and we have the Education Council and various committees. Today, we would like to give you a brief overview of pain management and some of the issues our patients face during the opioid crisis. If you do have any questions, we just ask you to hold on to them and ask us at the end. We'll be more than happy to answer them. Mary Jane will be happy to answer them. Well, I can but Mary Jane did a wonderful job on this presentation, and she's going to present 8/9 of it. So here she is.
All right. Thanks, Anne Marie. Thank you so much for inviting us to this meeting. I first want to say thank you to Dr. Baveld, and of course, thank you to Nora for reaching out to our group, the Massachusetts Pain Initiative. We're really honored to be here and to be presenting to you all. So I'm going to go ahead and share our screen with you. Can everybody see that? Okay. So as Anne Marie said, we're going to be talking about pain management in Massachusetts, a view from the chronic pain sufferers and their healthcare providers. And what we're going to be doing, our purpose first is to provide fact-based information for you, to provide a perspective of patients with pain, the less visible other victims of the opioid crisis. We want to provide you with a few important concepts about pain and pain management, and to give you some resources in the community. So first, in terms of opioid overdose deaths, the reports that are out there generally include any opioid, regardless of the presence of a prescription. And the growth of opioid deaths have led to a significant reduction in opioid prescribing, regardless of the medical need. There are numerous pain patients out there who were on legitimate doses of opioids who were forced to stop taking these effective pain medications and left to fend for themselves. As a result, some of them turned to the black market, leading to far more overdoses and deaths. Now, this here is a study that was done in Massachusetts. It was published in 2019, and it shows that Massachusetts was in the forefront of postmortem toxicology. This study here aligned the MassPat database with enhanced toxicology, and it did that for the very first time. The MassPat database, if you're unfamiliar with that, is a database of scheduled medications, including opioids. Most states in the United States have it. And this study also looked at almost 3,000 decedents, or people who died from overdoses between 2013 and 2015. The results from this study show that the majority of the decedents had heroin and fentanyl present. So almost 2/3, you can see here, had heroin present at death. Almost 50% had fentanyl present. 40% had prescription opioids present. And of those who had prescription opioids, 24% had opioids plus heroin and or fentanyl. Here we have the 40% that had any prescription opioids present. But here we also see that 16% had opioids present. However, there was no prescription at death, which then we can assume that these opioids were left over from previous prescriptions. These opioids were from maybe family or friends or off the streets in the black market. What's important here is to note that only 1.3% or 39 patients out of almost 3,000 had a current opioid prescription, and only that opioid present at death. So what can we conclude from this? That chronic pain patients on currently prescribed opioid therapy are not at high risk of death from overdose. Most fatal overdoses are actually caused by illicitly made fentanyl and heroin rather than from prescription opioids, according to the study. So what is the impact of the opioid crisis? This is what we see. We see about 2 million plus people affected by opioid addiction and death. And we see an almost universal focus to limit access to opioids to address this highly visible problem. We see this in our communities. We see this in the media, in the news, not only in Massachusetts, but everywhere. What we're not seeing, however, is the other side of the opioid crisis. We're not seeing the nearly invisible stigmatized people who feel like they're being treated like drug seekers. There are more people affected by death than those affected by cancer, heart disease, and diabetes combined. Providers and chronic pain patients are being targeted, and patients are being left to fend for themselves. Vinala Singh, who is the immediate past chief medical officer for the Department of Public Health and Human Services, wrote in this article just last month that in the shadows of the COVID epidemic is the US opioid epidemic, which is getting worse. And one group that is paying for this, but really shouldn't, are those who are living with chronic pain conditions. The opioid epidemic was initially fueled by misuse of prescription opioids that were obtained illegally. In more recent years, however, the majority of overdose deaths have been caused by illegal drugs or street drugs, such as fentanyl and heroin and methamphetamine and cocaine. So we're providing more data here for you. This graph looks at people living with chronic pain versus people with opioid use disorder. What you see here is people living with opioid use disorder, and this is in the millions. So 50+ million people living with chronic pain. And of those 50 million people who live with chronic pain, there are 20+ million people who live with debilitating high impact chronic pain. Here we have people with opioid use disorder, 2+ million. And this is by all means not to minimize the people who are affected and the families that are affected by opioid use disorder, but just to show you that this is what we see and this is not what we're not seeing. This is what we're missing. So some pain facts. You've probably heard the terms acute versus acute pain and chronic pain, but what are they? So acute pain is it's pain that's caused by trauma or injury, by surgery. It's pain that is treatable. It alerts us to danger. It's going to go away. Chronic pain lasts 3 months or longer than the usual course of an illness, and there is no biological purpose for chronic pain. Chronic pain, particularly high impact chronic pain, can be debilitating and life-altering. Untreated and undertreated pain can lead to many more serious health problems, including despair and suicide, and we've seen that. And the withdrawal of monitored and successful treatment with prescription opioids is devastating. So I want to go over some pain management terms that you've probably heard of: tolerance and dependence and addiction, and you've probably heard them used synonymously as I have, but they do not mean the same thing. So tolerance and dependence do not equal addiction. So what is tolerance? Tolerance is when the same dose is given repeatedly and it produces a reduced biological response. Or in other words, when you need higher and higher doses of a drug in order to produce the same response because you are tolerant to the drug. Dependence is when a person will experience withdrawal symptoms when a medicine is reduced or stopped, or a drug is reduced or stopped. An example of this is coffee, caffeine. So when you drink coffee every day, it has caffeine. Caffeine is a drug, and if you stop drinking that, you get a headache or flu-like symptoms. That's the withdrawal that you're feeling because you're physiologically dependent on that drug. Those are physiological responses. Addiction, however, is when you have this uncontrolled pathological pursuit of a drug. There's a willingness to do almost anything to acquire it, no matter what the consequences, and that is the difference. There is a craving and loss of behavioral control. So what's the reality out there for patient and provider? The reality for the providers is that they really want to do the right thing for their patients. But the reality also is that they fear regulatory scrutiny. What is the reality for the patients? These patients fear, they are so afraid that their medications are going to be taken away. These medications that allow them to be functional, that they were taking at stable doses. The reality is that when the providers stop prescribing because they're afraid of regulatory scrutiny, and these patients are abandoned, these patients can have to confront excessive hurdles just to find new providers and new pharmacies, all while being very limited. And the other reality is that they're not given any instruction on what to do next, no guidance, no follow-up. So what does untreated or undertreated pain look like? First of all, it's really important to take seriously because it can interfere with daily function. It can lead to social isolation, reduce the libido. It can interrupt sleep. It can lead to or worsen depression and anxiety, irritability, anger. Fear can lead to anger, despair, and hopelessness, and all eventually leading to high healthcare costs. So chronic pain, if any of you have ever experienced it, can be exhausting both mentally and physically. So what are some ways that you as laypersons, how can you address the psychological effects of chronic pain for someone that you meet? The important thing first is to know the signs and symptoms. So if you meet somebody who has signs and symptoms of chronic pain, what can you offer them? What can you suggest? Here's a list, and it starts off with distraction. Distraction can be as easy as just suggesting that person to do something that they enjoy, to try to get their mind off what they're feeling, the pain. It's easier said than done because when you're in chronic debilitating pain, it's really hard to focus on something, but encourage them to do things they enjoy. So FaceTiming with their grandchildren, coloring in a book, listening to music, listening to podcasts. So that's distraction. Meditation can be a form of distraction. If a person does not know how to meditate, they can look up guided meditation apps. There are lots of free apps on smartphones and iPads. Exercise is a way that can help the body and the mind. Psychologically, when you exercise, you release these feel-good hormones that help to reduce stress and anxiety. And low-impact exercises and stretches also can help and benefit the body and lower the pain symptoms that they're feeling. Massage therapy, the same thing, can help the body and the mind. Again, releasing those feel-good hormones, reducing anxiety. Massage therapy can also release the tension in muscles that help reduce stress and anxiety, and it can also increase blood flow to those affected painful areas. Biofeedback and cognitive behavioral therapy are more specialized therapy where you need a specialist, but they're really good ways to train the brain to respond to pain in a different way, or it helps the person cope with pain or manage pain on their own. But early diagnosis is key. Just like if you had any other disease, heart disease, cancer, diabetes, the earlier you diagnose the problem, the sooner you can develop a treatment plan and put it into action. So experts have found that many people with opioid use disorder first turn to drugs to numb the pain from depression and anxiety and other emotional trauma. Here is a graph, and this shows that almost 8 million adults have a co-occurring mental health and substance use disorder, which means that about 38% of those with substance use disorder also have a co-occurring mental health disorder. This circle graph shows that more than half of the 8 million people never have received, according to the article that this came from, have never received treatment for either diagnosis, and less than 10% received treatment for both. And of those who did not receive treatment, according to this article, about 24% reported that the barrier was they didn't know how to go about getting treatment. In the article that I referred to earlier, Dr. Singh notes that the COVID epidemic has increased social isolation, causing widespread mental illness, especially anxiety and depression. And not surprisingly, this has led to an increase in illegal drug consumption. And we want to keep in mind that untreated mental health disorders can exacerbate drug addiction, addiction disorders, and addiction disorders can exacerbate mental health disorders, and it goes around in this very vicious cycle. And this will continue until treatment efforts acknowledge that patients and providers can't address one type of disorder while ignoring the other disorder. So some of you may know this and be aware of this, but there's a lack of mental health crisis for services across the United States. And this has resulted in law enforcement officers serving as first responders to most crises in the community. This here is an opinion piece that Anne-Marie found in the Globe a couple of weeks ago, and this refers to an incident that happened in Newton. Some of you may be aware of it. I'm not going to go into all the details, but for those of you who don't know what happened, there was a young man with a history of mental health disorder. He was armed with a knife. Law enforcement were first on scene. After the 911 call, they tried twice to contain this young man with non-lethal strategies, but unfortunately were not successful. There was a health behavioral person on site, but because of safety concerns, nobody was allowed in the building. So this leads us to tell you that there are resources in the community. There are crisis intervention training programs. This writer is a physician, and he asked, could there have been other ways to, contain the situation, other ways to respond to the situation? And he asked to take a closer look at police training. There are many innovative programs in the community that provide training for mental health workers, law enforcement, for those in the service and healthcare professionals. And these programs create connections in our communities between all of these groups, including emergency room, community hospitals, and people with mental health and their families. And through these collaborative community partnership and intensive training, these programs provide tools to improve communication between the groups. They identify mental health resources for those in crisis, and they also ensure officer and community safety. So we wanted to give you some of those resources. Some of you may already participate. Some of your organizations may already, participate in these programs. But for those of you who don't know of these resources, there are 4 here, and within these 4 are an abundance of more resources. So the first is NAMI, or the National Alliance on Mental Health Illness. They provide crisis intervention team programs. The second is CPI, or Crisis Prevention Institute. This one is the Police Mental Health Collaboration. It's the PMHC toolkit that you can find on the Bureau of Justice Assistance website. And here the other day, I also found that there's funding, which is important because these resources are also at a cost or a fee. And down here is the Above program at Boston Medical. This is a holistic addiction and behavioral health outpatient recovery program. So a few more pain management facts that I'm going to leave with you before I turn it over to Anne Marie. So I want you to all to keep in mind that opioids are only one valuable pain management tool that we use for some patients with chronic pain. We like to use multimodal therapies. So we use opioids, but we also use non-opioid medications. We also use other interventions like the ones that I suggested, also acupuncture, reflexology, chiropractic, injections. So there's lots of things that we use out there, not just opioids. And the vast majority of chronic pain patients who are able to find pain management care do not become addicted to opioids. All right, so I'm going to hand this over to Anne Marie.
Hey, can you hear me?
Yep.
Okay. So I'd like to introduce you to Maria, a fairly typical patient who unfortunately we in the pain management arena have heard from often since the opioid crisis was realized and the CDC guidelines came out. So let's listen to what Maria has to tell us.
Hardware, the nuts and the bolts that came out of my spine. So this is the hardware, the nuts and the bolts that came out of my spine. So all this was in your back. Yeah. Maria Higginbotham has had 13 back surgeries. She's in so much pain, she rarely goes farther than her front porch near Tacoma, Washington. Her body's own immune system is destroying her connective tissue. This is probably 5 times worse than childbirth. 5 times worse. Every day, all day. For more than a dozen years, high doses of opioid medications through an implanted pump, patches, and pills kept the pain at bay. Her doctors say she never abused them, but 2 years ago they tapered down the strength of her opioid patch and pills to less than half what it used to be. I could go outside and plant a flower, I could walk my dogs, all those things I can't do anymore. She's tried everything from medical marijuana to steroid injections. Nothing else works. You feel like you're given 3 choices. You either live in agonizing, intractable pain that doesn't ever go away, or you go to the street and get the drugs off the street, which can kill you, or you commit suicide. She understands why the CDC issued new guidelines in 2016, encouraging doctors to consider tapering patients off high doses. Too many lives have been destroyed by abuse of opioids. But Maria and many other chronic pain patients feel they're being punished when they've done nothing wrong.
While I think there have been some good aspects that have come out of the CDC guidelines, there's been incredibly detrimental unintended consequences.
Dr. Sean Mackey, chief of pain medicine at Stanford, says those CDC guidelines have made a lot of physicians worry they'll be in trouble if they don't reduce prescriptions.
The fear is incredibly real. I am on the phone on a regular basis with docs who are being told just get people off opioids or get rid of those patients. Just get them out of the practice because everybody's running scared.
Mackey and 300 other experts sent a letter to the CDC last month, urging it to clarify the guidelines for patients like Maria.
I'm not involved in my life anymore, and I want my life back. I want to be able to function.
Lester, the CDC says doctors were never mandated to reduce or discontinue drugs. They're now studying the impact of those new guidelines. It is complicated. Doctors want to help those in real chronic pain without facilitating substance abuse, Lester.
All right, Kate Snow, thank you.
So we do see patients who have chronic pain and suffer. The CDC is now reviewing their guidelines and are working on updating them, making them clearer and more helpful for our chronic pain patients. What does this mean? Provider opioid prescription is not indicative of substance abuse, generally the opposite. There are numerous genuine challenges for providers and caregivers. Development of a therapeutic relationship is necessary, agreement on the plan of care, and follow through and adherence with that plan. There are similar brain pathways, terminology, and even drugs for pain and addiction. There is a need to address one without harming the other. Providers fear regulatory penalties and law enforcement resulting in abandonment of the patient in their pain care. Some providers have given up prescribing opioids totally, even when the patients have given no reason that they should not receive opioid pain medication, but have chronic debilitating pain. An opioid agreement between the provider and the patient needs to be fully discussed and binding for an effective treatment plan and therapeutic relationship So it's really important to have a therapeutic relationship with our patients who will comply to the agreement that we both have set up. Okay, what does this mean to you? We cannot lose sight of the less visible pain population that is being harmed by the current environment. Some of the guidelines limiting opioid prescribing are being applied much more broadly than intended and harming chronic pain patients. It's very challenging for you. Those challenges include confusion in recognizing differences in legitimate pain patients and those who are addicted. How do you do that? You do that with a systematic approach to each individual patient. In summary, patients with pain have been adversely affected by the opioid crisis, patients with chronic pain especially. They struggle to have their pain relieved with an effective pain management medication regimen. Although some have developed a dependence on and a tolerance to pain medication, they are not addicted. As Mary Jane told you, dependence and tolerance are normal responses to pain medication, but that does not lead to addiction. These patients want all that we have to be functioning members of society with their pain successfully managed. Maybe they won't be pain-free, but they'll be able to have their pain relieved and be comfortable and do what they need to do to be successful members of their family and society. All they need is appropriate and effective pain management. Compassion is needed to address the dueling public health crisis. Oh, can you go back?
Sorry, did that
Thank you.
automatically.
Compassion is needed to address the dueling public health crises. Millions of Americans living with chronic pain and overdose deaths from the use of illicit drugs. We need to balance that. This can be addressed by solutions that are right in front of us. As members of law enforcement, there should be continuous training on how to recognize mental health issues in patients with untreated pain, utilizing the that Mary Jane explained to us, NAMI, CPI, MCHP, and ABOBE. A team approach, including social workers and mental health workers accompanying law enforcement in crisis situations, would also be beneficial. In that article that I found in the Globe on the opinion page, the doctor suggested perhaps, since there was a mental health person with the police at that time, perhaps if they had isolated the individual and removed everybody from around them, cleared out the building or cleared out the area where he was in, and then brought the mental health worker in, perhaps that would have helped change the outcome of the sad ending that the patient had. So next would be the references, I believe. These references are what we used for our slides. They may be helpful for you, and you can glean a lot of information from these references if you would like to do that. And Mary Jane found this wonderful thing. Go ahead, Mary Jane.
Okay, thanks, Anne-Marie. So we wanted to leave you with this parting thought. Walk a mile in my shoes, see what I see, hear what I hear, feel what I feel. And this is our contact information if you have any questions, and the link to our website. Thank you.
Thank you for having us.
Thank you so much for having us.
Thank you so much. And
would it be possible to make a comment?
Yes.
Yes, you have comments?
Thank you. So I apologize for not participating regularly at these task force meetings. I did make a point of participating today because I saw on the agenda that the Massachusetts Pain Initiative was going to be presenting, and it's an organization that I'm very familiar with, unfortunately, because it's an organization that has been involved in advocating for what I believe would be aggressive and improper opioid use, in an organization that's taken a lot of money over the years from Purdue Pharma and other opioid manufacturers. And I don't doubt that Mary Jane and Anne Marie were sincere in their message today. I don't think that they're giving a presentation where they're lying to us because drug companies are putting money in their pockets. I really don't believe that at all. But when you look at the messages that come from pain organizations that don't take money from industry versus pain organizations that are funded by drug companies that make opioids, the messaging is totally different. So that, for example, pain organizations that are not funded by industry, one of their primary messages is that opioids are lousy drugs for chronic pain, that we harm far more patients with chronic pain than we help when we prescribe opioids, and that people with chronic pain have been disproportionately harmed by the increase in opioid prescribing, that the opioid crisis has disproportionately impacted people with chronic pain. And that's the message from organizations that are not funded by industry. Industry funded pain organizations, some of which are referred to as front groups in the litigation that counties and states are filing, their messaging is very similar to what we heard today. And certainly much of what Mary Jane presented, I would agree with, and I think is important. People with chronic pain do suffer, and we do need to do a better job of meeting their needs. But this framing of the opioid crisis as if you have these two distinct groups of people with chronic pain who are helped by opioids versus people who abuse opioids and are harmed by them. And this framing of the problem as if any kind of reduction in opioid prescribing to address the crisis is going to punish people with pain. That's something you hear consistently, and it's something we've heard today. And it's why a lot of these groups have been attacking the CDC guideline. And we're increasingly seeing this message. Public relations firms are getting the media to put out a narrative that the pendulum has swung too far, that pain patients are suffering because doctors don't prescribe enough opioids. And much of that messaging is really not appropriate. It is very true that many people in Massachusetts and millions of people nationally with chronic pain have been put on opioids. And it's very true that they're not going to be able to come off easily. It's also true that some doctors are starting to get the idea that they shouldn't have treated backache with long-term opioids, and they're stopping patients too abruptly, tapering people too quickly or cutting them off. That is a serious problem that needs to be addressed. We really do have to help these patients, but we shouldn't pretend that it was appropriate for these patients to wind up on opioids in the first place. Again, these are not good drugs for chronic pain.
Thanks, Andrew. Mary Jane, Anne Marie.
I just like to make a comment. We are not funded by anybody. We're not funded by any drug companies. We have never taken money from drug companies. We're an independent volunteer organization that does advocacy for pain patients. We have been fastidious to make sure that we have not ever accepted any drug money from anybody. We raise our funds by giving educational programs. We have never been in anybody's pocket, ever. We have not started off that way. We were an arm of the American Cancer Society many, many years ago. Then we were let free from the American Cancer Society. We are now our own independent organization, nonprofit organization, and we do not take funds. We have never in the past taken funds from any drug companies. We are an advocacy organization for patients who suffer from chronic pain.
Marianne, I'm sorry, Anne Marie, that's not correct. The funding that from the beginning, it was actually not so much the American Cancer Society, but it's actually the Cancer Action Network of the American Cancer Society where the funding came from. That was a pass through from the opioid industry. Cindy Steinberg, who I don't know if she's your executive director or what her title is, has been a key player for opioid front groups to this day. She works for the U.S. Pain Foundation. She worked for the American Pain Foundation. These are organizations that have been investigated by the Senate Finance Committee. There's overwhelming evidence about the ties between Massachusetts Pain Initiative, particularly through Cindy Steinberg, and the opioid industry. But it is, I don't doubt that you haven't put, I certainly believe you that you're not putting money in your pocket from the opioid industry, but Cindy Steinberg certainly is, and I believe she's been involved in running the Massachusetts Pain Initiative.
That's not true.
I'm going to interject if I may. I'm Antje Barveld. Andrew, we've met before. I'm the medical director for the pain management services at Newton Wellesley Hospital. I think in the interest of the whole group, I think it would be important to take this conversation offline in regards to the funding for the Mass Pain Initiative. And Anne Marie and MJ Estrada, I can introduce you guys over email too. I thought MJ or Anne Marie, maybe it would be interesting to hear from you in regards to Andrew's comments about the challenge we have about managing pain, as Andrew alluded to, and what is the role of opioids in chronic pain management. And we saw the video where we know Sean Mackey is obviously a very prominent figure in the pain world. This debate continues to spiral within our pain communities as well as nationally. And I would say that there's almost two separate issues: patients who have been on chronic opioids and then those that we start on chronic opioids for pain. So I think making that distinction is important. And I don't know if MJ, you wanted to address that. Put you on the spot.
Sorry. Yeah, so in terms of patients with chronic pain, yes, for those who had been started on chronic pain, chronic opioids many years ago, we do our best to try to, bring down the doses to the least effective dose. And when we start a patient on opioids now, we try everything before we ever put anybody on opioids. It's not the first line by any means. We try conservative therapy, we try other therapies, but we do not start them right on opioids. I think there needs to be a balance when you're treating somebody with chronic pain. We certainly don't want to, like you said, just get them off the opioids, but we want to be compassionate to these people also.
And as we know, Andrew, this is just and we know that you really are a well-spoken voice on the side of caution for opioids, and we should be concerned about how much we have prescribed in the past. I think now when I talk about my own practice, I don't think I've written an opioid prescription for chronic pain for a new person in a very long time. Recently, we had a 92-year-old woman with debilitating osteoarthritis. She can't walk. She's suicidal from the pain. Am I going to deny her opioids because they're not a great drug? And there's debates about the role of opioids in chronic pain. I mean, in her case, of course, I think this is more palliative, but we don't have palliative care services that care for non-cancer patients easily accessible. So, I think we grapple with this question every day, and I think the whole pain community understands that opioids are not the first line answer ever. And our patients understand that, but we do have a lot of patients that feel very stigmatized because they've been on chronic opioids, they're highly functioning, they go to work, they take care of their family, they're not sitting around. They really are able to function because they feel the opioids are helping them. And so now we are in a difficult situation where we would like to be able to, of course, to reduce the amount of opioids that are prescribed in our communities, but we need to look at every patient individually. And it's not a one size fits all. And I think that's where the challenges with the CDC guidelines really came to the forefront, because there was this kind of, and with the opioid epidemic and obviously the horrendous impact this has made on our communities and families, we got a little too quick to pull back, and I think a lot of patients have suffered as a result. So we could talk about this forever, and it's something I feel very passionately about. And I think, Andrew, really important that you brought up those issues. So I hope that we kind of address that, and would like to open it up to Andrew if you had anything else you wanted to say, or anybody else, of course. You're still on mute, Andrew.
Thank you.
Yeah, just a couple more points that I'd like to make. There are certainly patients on chronic opioids who will say that without opioids, they wouldn't be able to get out of bed, walk the dog, that it's the only thing that helps them them function. And I treat opioid use disorder, and I can tell you that the patients who I treat who became addicted through chronic pain treatment, or my heroin use patients who have been heroin users, they say the same thing. That they used to keep heroin by the bedside so that they could use as soon as they wake up. Otherwise, they wouldn't be able to get out of bed. They'd be in so much pain. If you're on opioids chronically, it's absolutely true that before your next dose, you're feeling excruciating pain. Doesn't mean that the opioids are relieving their chronic pain. This idea that the CDC has harmed pain patients, really, I think that's a false narrative that's being pushed. What the CDC did was to introduce basically guardrails to say that for acute pain, we shouldn't go past 7 days. For chronic pain, we should avoid going above 90 MME. Have some patients on chronic opioids, have they had their opioids drop too quickly because of a misunderstanding of the CDC guideline? Certainly that could have happened, but overall, and we don't have good data on this, it's very likely that the more cautious prescribing that's resulted from the CDC guideline has prevented many people with chronic pain from becoming addicted or from overdosing on their medication. And despite this narrative, you saw it in the media coverage, that we've gone too far. If you look at opioid consumption in the United States and you compare it to other countries, there is still no other country on earth that comes close to prescribing as much opioids as we do. We still have a very long way to go before we get to rational levels of prescribing. The trends are good, and I think you've just explained in your own clinical practice, less patients are getting started on opioids. That's terrific. That's the direction we need to move, but I'm worried it's gonna be harder to get where we need to go when there's this narrative out there that we're punishing pain patients in our efforts to address the opioid crisis.
Well, I think that is a piece of what we hear and we see, and that's the part of the value of these meetings, is to have that debate, to bring out those pieces. So thank you for that part. Thank you to Anne-Marie and Mary Jane for that presentation. Did anybody have like one last question before we move on to next? All right. Thank you both.
Thank you.
Awesome.
Sort of changing our focus, our next speaker comes to us from Mass Hire. Alexis Sacanti is a program manager at the Mass Hire Career Center, which serves Greater Lowell. There are, in fact, these career centers in every major part of the state. Some have branch or satellite offices. And the idea is that the services are tailored at each center to match the communities they serve. So Alice is going to talk to us about a grant that they have, which fortunately was recently renewed for another year to serve people who are struggling with opioid use disorder. So Alexis, thank you so much.
Hi, thank you for that. So I'm just going to share my screen. I have some PowerPoint slides, but most of my presentation is really just discussion based. I like to put the slides up there so that people can take notes if they like. They can just kind of have a summary of what I'm saying. If they get distracted, they can just look back at the screen and see what's up. But it's just a very small amount of slides. So let's see here. So we will start that presentation. Okay, so if everyone can see that, I thought that I would provide first just an overview of what the career centers in the state provide to the communities that they serve. I find that Mass Hire as an agency tends to kind of have a vague purpose when it comes to providers and knowing what it's for and how to use it. Most people are familiar with the Career Center when they're working with clients who are collecting unemployment or who are receiving services through DTA, particularly if they are cash benefits recipients. DTA often requires them to work with the Career Center to gain job skills and knowledge and get back to work as a condition of receiving these services. Additionally, when you are on unemployment, you're often enrolled in a program which is called RICEA, and that program through the state requires you to apply to a certain number of jobs each week, with the intention of helping you get off unemployment and reintegrate into the workforce. So Mass Hire is the provider of those services as a partnership. But another aspect of what we do is we work with walk-in unaffiliated residents in the community, who either have lost their job but are not collecting unemployment, or they're unhappy in the work position that they're in and they would like to make a career change. We have a multitude of youth services. So we help people who are just starting their careers as well. We receive a lot of funding from various parties to conduct training grants. Often they're in much needed professions in the region. It's based, each career center's grant is based, as you said, on the region that they're in. So for us, manufacturing, IT, pharmacy technicians, and medical assistants are very, very in demand professions. So our training grants tend to focus on those. We have upcoming a grant partnership with Shawsheen Technical Institute that is going to be running at night and training people in automotive skills, because those are currently in demand as well. So there's a lot going on at the Career Center at all times. The core of our services focus on job searching assistance and access to job listings. We have a database that it functions similarly to Indeed, that just gathers all these listings, either that we've acquired personally, or that we've managed to pull off of the web and things like that. We also offer career counseling. We have a multitude of skills assessments. We have some online training modules and skills testing programs that will allow you to kind of demonstrate that you're proficient in this, you're proficient in that, that sort of thing, to help you kind of guide what your next steps will be. We also do a lot of workshops on job search strategies, how to present yourself as a professional, working on your resume, practicing interviewing skills, and more importantly, addressing difficult questions when it comes to seeking employment. We have a number of population-focused workshops, such as workshops for mature workers, which the Department of Labor defines as anyone over 55, which is devastating because that is not a mature worker, that is a person. But there is often barriers to re-entering the workforce when someone presents as an older individual. So we hold specialized workshops to help them address that in interviews and really present their skills as valuable to employers who might be more interested in hiring a younger, less expensive worker. We also offer workshops on answering tough interview questions regarding felonies and criminal background, or large gaps in employment, which is particularly relevant when we're working with people with substance use disorder, as often the work history is spotty. There can be many years in between jobs, whether that individual was incarcerated or in treatment, or unfortunately just transient. There's a multitude of reasons why people with substance use disorder have a less than stellar work history. We also have a veteran services representative who works with people in the community to connect them to their veterans benefits, and also to specialized services regarding connecting veterans with work. On the employer side of things, the Career Center also works with local businesses to help them find the workers that they need. So we have a department that works very closely with companies in the area. It functions partially as a headhunting situation, but also kind of as a recruiter. So the company will say, we need CNC machiners. We have 3 openings, and the business services team will connect with our career advisors, see who is currently working with the Career Center who has that skill set, and make the connection. The person still has to get the job of their own volition. So, you know, they would interview just like everybody else, but bridging that gap and connecting one need to the other often really helps that person get the job that they're looking for. We also went in situations of layoffs or business closings or things like that. We usually help the employer take care of their workforce before the last date of employment. We try really hard to do that, so that way if a company kind of goes out of business or does a mass layoff, we don't have large numbers of people signing up for unemployment, entering the workforce with no job. We try to just streamline them and connect them right to something else. So that's what the Career Center as a whole does. So this grant specifically, we're calling it the Career Recovery Project. Often it's referred to as the Opioid Grant. It was awarded to us in 2019. The total award was $2.5 million. It was given to us through the Department of Labor. It's the first grant of its kind. It was designed from modified funding that's usually reserved for national disasters such as tornadoes or hurricanes or things like that, where the Department of Labor just infuses a lot of money into a region that's been hit very hard by a disaster of some kind, to help with reskilling, to help with employment services, and to help with the rebuild efforts. So in that vein, the opioid crisis has been declared a national disaster, which freed up the Department of Labor to pivot this funding into a non-traditional use, which is to connect with people who have been affected by the crisis and reskill them into other professions, get them vocational skills to begin with, and really just take the steps needed to help reintroduce them into work. So the award included funding for staffing, training services, supportive services such as, you know, funding for work uniforms if our customers were hired and didn't have the cash available. Transportation in some regards was included and covered, as well as the standard array of career services. One of the most important aspects of the grant, which took place this last year, was our work experience program. The grant enabled us to work with partners in the community and place our customers who are enrolled in the grant with those agencies to get hands-on experience in a supportive employment position that was paid for by the grant. So these agencies who worked with us got the benefit of additional hands without the strain of extra staffing costs. So that was an incredibly beneficial aspect of this program. Several of our local agencies benefited from it. The vast majority of them were ones who were supporting the community in substance use services and homelessness services. That's where the majority of our placements went. That funding for this year is unfortunately exhausted. So we're no longer able to continue that, but what we will be continuing for is training services and career advising. So one of the questions that we get a lot is, who is the grant specifically targeted for? It's a really wide open eligibility criteria. We wrote this grant specifically to address people who are in recovery from opioids, but also people who are indirectly affected by having a loved one who is in recovery from opioids. So we hear often about maybe a mother whose son is in treatment and is going to outpatient every day and needs rides and needs lots of care, or needs to be supervised at home by the loved one. And so they have put their career on the back burner while they attend to the needs of their loved one. And they just never reestablish their career. Maybe they're working a part-time restaurant job so that they have the schedule flexibility to take care of their family. We find that not a lot of grants address that population specifically. So we wanted to make sure that this one did. So you can be either a person in recovery, or you can be indirectly affected by the substance use disorder. So the main criteria for qualifying for the grant is you need to be unemployed, preferably as a result of the opioid crisis, as you're perhaps struggling with addiction and you were terminated from your job, or you left your job because you were unable to focus on keeping your employment. Currently, with the pandemic as it's happening, many people are falling into the second criteria, which is being unemployed for a period longer than 27 weeks. That's 27 weeks in the aggregate. So we can kind of take a look at their work history over the last year, and if there have been large periods of time where they work for a month and then don't work for 3 weeks and then work for 2 months, and then where it's all broken up, we're able to add all those weeks together that they were not employed. And if it's 27 weeks, they would qualify as well. We really wanted to be flexible with getting people into the program. Another aspect is underemployment. So underemployment is your annual income is at or below 200% of the federal poverty level for your household size. You're working a job that is below your credentialed skill level. So think about if you have a bachelor's degree, or if you have a medical assisting certificate, but you're working what's often referred to as a get well job, you would be underemployed for your skill as a professional. Or if you are working a job that you needed to take because of the crisis, that is 80% or lower of what you were making before. Most of the time we see this with loved ones who have left their jobs to take care of a person struggling with the opioid crisis. There are a few other conditions for qualifying, but they're very specific and quite in the weeds. So I try to tell our partners that if you have questions, just feel free to ask or send the referral anyway, and we will figure it out. We're trying very hard to get as many people in here as we can while we have these funds. So the grant was extended for another year. So it's now ending in December of 2021. What we're currently able to offer is all the services offered by the Career Center, which is career planning, vocational exploration, direct connections with employers in the area, assistance with job searching, a number of workshops and professional development seminars. We also offer HiSET and GED, and those supportive services that I mentioned before. The biggest aspect of this grant is that there is funding for training. If someone comes into the grant and they're able to demonstrate that the skill set and experience that they have is not sufficient to maintain employment, or that the training that they have is no longer tied to what's called a positive outlook profession, which Department of Labor defines as a job that's expected to have an increasing number of jobs over the next 10 years. We are able to justify that as a reason to send them into training in something else. A lot of the people who have taken advantage of this grant have fortunately decided to go into training programs for professions that are going to give back to the recovery community. We have several recovery coaches who are on their way to certification. We have about 8 people who are participating in the LADAC program at Middlesex Community College, and a wide number of people who have either gotten jobs or are working on gaining experience and training in human services in general. So we've seen our outcomes have a really big impact on the Lowell region and a little bit beyond that in terms of increasing the number of available providers, which is a really great thing in addressing this kind of bottleneck in, people who need treatment and people who are qualified to give it. So that's been a huge change, and we're glad to offer it. So the process for submitting referrals is relatively simple. If you're an agency who plans on regularly submitting referrals for your clients, we are able to set up a direct online portal for you. We would give your agency credentials and a password, and you could just electronically refer them right to us. And we would begin the enrollment process from there. Otherwise, people are able to contact me directly, or they are able to contact the Career Center and just specify that they are interested in this grant, and they can self-refer, and that's totally fine. So this is my contact information in case anybody has anybody that they're thinking of right now and saying, oh, this might be good for that person. Or even if you just have further questions about the program. One of the things that I will say is that in terms of people who are a good fit for this program, we ask that providers use their best judgment when they're sending in referrals, on whether that person is ready to go back to school or ready to re-enter employment full-time. Sometimes we get referrals where it's a financial hardship referral. They're either imminently going to a sober home and will need to pay rent, or they're struggling with some other lack of income and they're being sent to us because we can help them get a job, hopefully. We find that sometimes those people, perhaps they're trying to get work too quickly because it's a need, and they don't maintain that employment, which unfortunately for this grant has negative repercussions because the Department of Labor is unused to programs that have a high rate of dropout. This is, like I said, this is the first grant of its kind. So they are not really familiar with the ebb and flow of customer participation when working with customers with substance use disorders. So we are graded on our program outcome goals that are very high bar for placements of jobs and retention of jobs. So I think really just ask yourself, is this customer ready? If they're just looking for employment and they don't need these additional supports, we ask that you send them through the Career Center itself, because those services are free as well. So that's that's what we're doing. I would love to know if anybody has any questions.
Wonderful. Thank you. Thanks, Alexis. Questions? All right. Wonderful. Can you stop sharing?
Sure, of course.
All right. Wonderful. Thanks, Alexis. Then we can see better if people are raising their hand.
Sorry.
There you go.
Any
Any
questions?
questions?
I do.
Yeah.
Hi, I wanted to know, well, relevant to, I do have somebody in, I'm in recovery court. I also have a lot of people that are in the sober homes that you had mentioned,
Mhm.
but I would be very selective as to the now moment for you, certainly. But what I'm interested in is, yes, they're placed in positions where they just had to take a job, that whole mandatory, but they're looking for a GED to better place themselves in a better position.
Mhm.
So would that be a good to you or to the Career Center?
So we do offer GED services in our program. Quite a few of our customers have taken advantage of the GED offerings. We're partnered with a BC Adult Education Center. They're our instructor. It was offline for a little bit due to converting to remote services, but we're back on the wagon. We say that customers who are referred to us and are looking for a GED, the expectation if they're involved in our program is that once they obtain their GED, they'll work with us beyond that to find employment. sometimes there are people who are sent to us who are looking for their GED because it is something that is a goal for them, and they feel that,
Want me
this
to
is a
talk,
milestone they
Paul?
want, but that they don't want to go on for work.
No, I'm
So-
gonna
Okay, so
do
that's
it.
exactly what I needed to hear because I have somebody involved in Roca. And yeah, so they're more like, get your GED, get your GED. But he's looking for
What?
something to take further on after he gets his GED. So
Right.
the Roca really isn't going to work for him
Mhm.
in that particular situation. So this is great. You'll be hearing from me.
Okay.
Wonderful.
Hi, Alexis. It's Bill Garr from Lowell House.
Hi.
I just want to say hello and thank you. We've had amazing work with you guys. I'm so glad to hear you have another year.
Yeah.
I don't think a lot of people know about it. So, you know, I think we really need to pass the word. And I'm sorry the internship program isn't running because a
Yeah.
number of people went through our programs and we've hired several. It's been a wonderful program.
Yeah.
But I do mention we have a couple of people that have gone through your program that are in our Recovery Coaching Academy.
Yes.
And I know Matt has a class coming up, and we're
Mhm.
also doing several paid interns out of those classes. So
Yeah,
there
we
will be
have a few in your February class as well.
I know February classes I think is about full. But Matt, I don't know if you're still on, but we do have a spring class, and you know, our objective is to get enough recovery coaches, both us and the community. And boy, there's a great need out there. So thank you, and we'll pass the word around.
Yeah, thank you.
Yeah, we're still looking to lock in the date for the spring class, but stay
Yeah.
tuned. That'll be on our website, and we'll send out announcements. when that happens.
Yeah. So that's definitely something that we're keeping our eyes on. We're trying to increase the number of trained recovery coaches that we're putting out. We have, I think right now we're at about 9 who have been in our grant, who have gone through the recovery coaching training. A few of them are ready to be certified. They've achieved their 500 hours and they're ready to hit the ground running, but we're always looking to add more. So that's been really great. And Megan's House and Lowell House and the Bridge Club of Lowell, CTI, and a few other agencies have been really good partners for us.
Terrific. Thank you.
Right. Any other questions? Thank you.
Yes,
Thank you,
thank-
Alexis. That was,
Oh, Rita. Rita.
Yes,
oh, sorry, go ahead. Rita.
yes. Alexis, thank you very much. That was very informative.
Yeah, thank
I'm
you.
concerned about, and I'm concerned about this grant, which was so helpful here in that it provided people to get paid while they worked in places like the Bridge Club or CTI or
Mhm.
24-hour power recovery,
Yeah.
the Elliott Church, Megan's House, all these organizations, as well as the Middlesex Sheriff's Office where I work. And I saw
Yeah.
people that, you know, could have probably been dead, but
Yeah.
now they turned their life around and now they got some self-esteem because they got a job and they pride in that. And then the funding ran out. I'm thinking about more people. Could we not hire people to put them back in these services to help, like New Challenge? The Tewksbury Police could use some help, and
Yeah.
could we do that? Could we spend the money? Because what I'm understanding is they while we have funding to keep our internal staff on board, they
Mhm.
ran out of funding for the work experience line item.
Right.
So
Yeah.
I'm concerned about people that, such as these people that turned over a new leaf and got momentum to try to get a job
Right.
and keep it, you know?
Mhm. Right.
So do you think maybe we'll,
So unfortunately,
Go
the
ahead.
way Department of Labor structures their grant disbursements is when you apply for the grant, you have to dedicate specific budgets to different things. And if you need to make a modification, such as moving funds from one particular line item to another, you have to submit a formal request for a modification, which then has to go all the way to Washington and come back to us. We've actually already submitted a request for a modification. We did that back in April to increase the funding for our work experience program because we wanted to support these agencies that had become really reliant on our worksite placements as at meeting the needs of the community. And that took about 4 months to be approved. So we would love to increase that funding and move things from column A to column B, but at this juncture in the grant, with everything going on in Washington, with the pandemic, and with obviously a lot of political unrest, the modification would take months and months and months. And by that point, the needs of our partners and the needs of the individuals who are participating, they would be far worse. So what we're trying to do for the people who are in our work experience, who are looking for employment elsewhere, or for our partners who had interns, we're trying to work with them as best we can on continuing to either put them in training for another skill set now that they've become accustomed to showing up to work every day and having a regular schedule, or finding them permanent employment in the community. Because like you said, some people have really, really turned their lives around. There are a few of our customers who have been on the streets for years, and they've held this position for upwards of 8 months. And we're very, very proud of them. And we continue working with them beyond the grant for an entire year. So we support them in refinding employment if they lose their job, in finding employment if they didn't manage to get hired by their work site, which many of our work sites did keep their placements. We're very, very grateful for that. But unfortunately, it's just the way that the Department of Labor structures their grant dispersals. We would not be able to modify that at this time. So we're focusing on supporting them to finding permanent employment so that they don't lose this momentum that they've worked so hard for.
Yes, thank you very much, Alexis. I really can agree with what you're saying, although I feel whatever works, they should have kept it, but they didn't.
know.
I'm sorry, but you're trying very hard. I understand.
No,
Thank
yeah.
you so
So
much.
I mean, the budget that existed was meant really only to carry us through the end of 2020, because that was the initial grant period. We applied for an extension because we still had so much funding left in the training portion of our line item. So we wanted to make sure that we had the opportunity to spend that down so that the whole 2.5 million could be infused into the community. Because when you don't spend all of the money, as we all know, you have to give it back. And we really
Don't
didn't
do
want
that
to happen. So
don't give it back. We need it. Thank you so
yeah,
much.
I know. So we applied for the extension in order to prevent that from happening, but the extension doesn't come with additional funding. It just gives us extra time to spend what we have. So there was no opportunity to apply for more.
Great job.
Thank you. That was great, Alexis. Thank you. Anybody, I know we're running to the end, but anybody have any announcements or projects or things you want to do? I have, and I know this is short notice, but we received a notice which Nora sent me for a program that is actually today. But Nora, do you want to can you put that announcement in the chat? Maybe?
Absolutely, I will. It's a thing that's being sponsored by the T.H. Chan School on opioids and or COVID and mental health, and it looks to be a really good program. And Chan always records their programs. I'll put the links in the chat. And then there was one other, which was a note from Jean Granick at Cambridge Health Alliance. And she just wanted to let folks know that they are contacting all of their patients who are 75 and older to try and schedule appointments for vaccines. And so to the extent that there are folks out there who are feeling that it's very hard to get appointments, they should be hearing, at least those who are participating and are part of Cambridge Health, they're affirmatively reaching out to everybody at this point.
Yeah, because things seem to be blowing up with people's ability to get that connection, but I'm sure it will hopefully work itself out in the next few days. All right, we do not have a date yet for February meeting, but we will do that. We just need to be finalizing with our speakers. Again, I want to thank all of our speakers this morning. Those were two very good, very interesting presentations, always helpful, and hopefully both are useful to folks that came out. And again, thank you for making time to be here with us. Thank you, Nora, for making this all work. And stay well. We'll see you next month. Thank you.
Thank you.
Thank you.
Thank you.